Based on the most recent clinical trial data and guidelines, the role of the intra-aortic balloon pump or IABP has shifted from a primary routine therapy to a highly selective niche intervention. While it remains the most commonly used mechanical circulatory support device globally due to its relatively low cost and ease of insertion, its clinical standing has been significantly downgraded. The most significant recent update is the 2025 ACC/AHA SCI guideline for the management of acute coronary syndrome, which officially aligned US practice with earlier European restrictions. Routine use in cardiogenic shock following myocardial infarction is class 3 now, no benefit. ESC 2023 also same, class 3. For mechanical complications like ventricular septal rupture and acute ischemic mitral regurgitation, it is a class 2A reasonable recommendation in ACC/AHA 2025. For high-risk percutaneous coronary intervention, it is class 2B, may be considered. So, routine use in acute myocardial infarction-related cardiogenic shock is now class 3, harm or no benefit recommendation across all major societies. The downgrading of IABP is rooted in several landmark trials that failed to show a mortality benefit, contrasting with newer data for more powerful devices. IABP Shock 2 trial. The definitive blow to routine IABP use came from this trial. Recent 6-year follow-up data, EPUB late 2018, showed no difference in all-cause mortality at 30 days, 1 year, or 6 years. That is approximately 66 to 67% mortality in both groups at 6 years. And there was no improvement in quality of life or recurrent myocardial infarction rates. The Danger Shock trial compared a microaxial flow pump against standard care, which excluded IABP. 355 patients were included in the final analysis. Impella CP reduced 6-month mortality in STEMI cardiogenic shock compared to standard care, 45.8% versus 58.5%. Composite safety endpoint was severe bleeding, limb ischemia, hemolysis, device failure, or worsening aortic regurgitation. There was a higher incidence of composite of adverse events with the use of the microaxial flow pump. Impact on IABP. This trial provided the first high-level evidence that higher power unloading, that is 3.5 liter per minute versus IABP's less than 1 liter per minute indirect increase in cardiac output, is required to influence mortality, further marginalizing IABP as a standalone shock therapy. The ECLS shock trial showed that routine VA ECMO did not improve mortality in acute myocardial infarction related cardiogenic shock. Interestingly, many centers still use IABP in combination with ECMO to reduce the afterload of the left ventricle. ECMO can increase afterload of left ventricle. While some registries suggest benefit, randomized data for IABP as an unloading tool during ECMO remains neutral. Despite the no benefit label for routine use in shock, IABP is still utilized in specific high-value scenarios. Mechanical complications of myocardial infarction. It remains a bridge to surgery for acute mitral regurgitation or ventricular septal rupture by reducing afterload and increasing coronary perfusion without the high shear stress of axial pumps. In ventricular septal rupture, IABP has been shown to reduce left to right shunting and improve hemodynamics in patients with and without shock. Favorable hemodynamics have been noted in acute ischemic mitral regurgitation as well. High-risk PCI, that is prophylactic use, used in protected PCI for patients with precarious hemodynamics, multivessel disease, or last remaining conduit scenarios where temporary stability is needed during balloon or stent deployments. Bridge to advanced therapy. In case of chronic heart failure worsening, IABP is often used as a bridge to a left ventricular assist device or heart transplant because it allows for patient mobilization, especially if inserted via the axillary artery. IABP provides diastolic augmentation and systolic unloading. It increases coronary blood flow, myocardial oxygen supply, and mean arterial pressure. It decreases afterload, myocardial oxygen demand, and pulmonary capillary wedge pressure.